and welcome to Advanced Operations Module 1. In this video, we're going to talk about geriatric emergencies, disaster management, and managing stress in the first responder. Our first topic we're going to cover is going to be geriatric emergencies. The objectives we will cover in this first part will be to review the psychological and physiological changes that are going to occur with age. We'll describe common emergencies and proper techniques for assessing the geriatric patient. We'll explain the purpose of advanced directives, living wills, and hospice care. And we will finally discuss topics of elder abuse. So for this class, a geriatric patient is going to be someone that is 65 years or older. As we get older, there are going to be many reasons and causes for emergencies, medical and trauma. There are also many options for long-term care when it is needed. The geriatric population is going to rise significantly in the next few decades. By the year 2030, it's estimated that there will be 72 million geriatrics. It will increase to 84 million by the year of 2050 and continue to rise thereafter. In 2030, there will be more than 7 million people over the age of 80. Geriatrics currently account for a quarter of emergency room visits and admissions, with the statistic increasing with the age. Since the population percentage is estimated to increase, responders should have a knowledge of the aging process and possible geriatric emergencies that they would encounter in the field. We'll start with the heart. The heart begins to slow down and blood pressure isn't regulated like it used to be. So it makes syncopal episodes very common. The SA node that is also known as the pacemaker of the heart, begins to fail. It starts to slow down. So the AV node takes over as the pacemaker, and then if that AV node begins to fail, the pacemaker continues on further down the heart. So when this happens, the heart rate gets slower. The muscles begin to work a little bit harder. Common things that can occur in that heart muscle are going to be left-sided failure and right-sided failure. You can have a left-sided heart congestive failure. This is when fluid backs up into the lungs because the left side is not able to pump correctly. When right-sided heart failure occurs, it causes fluid to back up into your body, the systemic system. So you'll have edema and problems there because now the right side is not able to pump effectively. You can have either left side or right-sided, or you can have both, which would be complete heart failure. If the left side begins to fail, eventually the right side, who is now working harder to pick up for the left side and to work against it, will also start to fail. Common things that can cause heart failure can be electrolyte imbalances, uncontrolled hypertension, and myocardial infarctions. So if a clot develops or if it lodges in the coronary arteries, it can cause a heart attack. This can cause a lethal arrhythmia and possibly death if not treated appropriately. Even after heart attacks are treated, they can have long-term effects. You can have respiratory changes as you get older. Most geriatric patients have a rib cage that is weakened. It doesn't allow for full expansion. And we call that expansion compliance. So not having full compliance will not allow for a full breath. Most people begin to hunch and begin to shrink. If there's a walker involved, they hunch over and use a walker. So the rib cage alone starts to diminish in size normally. So now you are having problems with expansion of the lungs and things being too tight. So the breath that they could possibly take standing upright is not going to be as much volume as it would be. So COPD, pneumonia, and other illnesses can also potentiate this expansion problem. When you have inflammation or obstructions on the inside, it's caused by restrictive airways. So restrictive and compliance problems are very common. They're unable to take full breaths and become hypoxic pretty quickly. Airway muscles can begin to weaken. They can develop problems swallowing. So this causes aspiration and choking. Choking can be either partial, where you get little air to move around the obstruction, or it can also be a complete airway, where Heimlich maneuvers and CPR compressions are needed. The bones of a geriatric patient will become weak, and the cartilage becomes thin. Your balance gets off, and walking begins to become difficult. Minor injuries can cause fractures to bones. The picture on the right is going to show you the difference between the spongy bone, the inside of a normal bone, and the inside of a bone with osteoporosis. Our bodies go through constant remodeling of their bone structure. There is old bone that is removed and new bone that regrows. When the removal process starts to outpace the regrowth process, the bones become porous. So this bone removal also happens on the inside of the spongy bone itself. And so hence the porous part of it all. These bones become brittle. So fractures are super common for these patients. There is no cure for this disease, but treatments can help. Risk factors that have been known to be linked to osteoporosis are going to be low calcium intake, so poor nutrition, smoking, low estrogen and testosterone levels. Eating disorders can also cause osteoporosis. Your kidney function begins to decline at the age of 40. On an average rate, it starts to decline at 1% a year after that. Of course, everybody's a little different. And I believe now we are beginning to be more of a gluttonous in nature. So the possibility of going into renal failure quicker is there and more relevant now. Your kidney tissue, nephron size, and the numbers will decrease. The arteries that supply your kidneys begin to narrow. The blood supply reduces, and this can cause the actual size of your kidney to reduce. They can become lighter also when this happens. Your bladder can have a number of difficulties with it when aging. The pelvic floor muscles and the bladder muscle itself begin to weaken. Some disease processes like arthritis can make it difficult to get to the bathroom in time. Parkinson's, MS, diabetes can also cause nerve damage to the muscles that control bladder function. So when kidney disease becomes advanced, dialysis is needed to remove the waste products from the body and the excess fluid. And it also needs to get replaced if replacement is needed with cleaner, fresh fluid. Our psychological changes as we age. So 7 million elderly are affected by depression in some form of fashion. Only 10% will seek help. It often gets overlooked when there is another health problem or medical condition involved. Geriatric depression stems from being lonely, financial problems, their spouse dies, they don't want to be a burden on their family. There are many, many reasons for depression in the elderly. It comes as a mild, a kind of moderate, and a more severe, where a mild form of depression lasts just a few days. And there's minor things that are involved with it, where a moderate is all of those symptoms plus eating and sleeping problems, and it gets a little bit more severe and lasts about 2 weeks, maybe a little longer. But once you start going past that 2 weeks, it becomes a more severe type depression. Anxiety that can occur with your geriatric population is difficult to diagnose. There's a portion of the population that does not want to talk about their problems. There is anxiety that is coupled with exacerbation of certain medical conditions can make those even worse. So your COPD exacerbation, if you couple that with anxiety on top of it, it is going to make their respiratory distress even worse. There's about a 20% of the geriatric population that has anxiety. Social phobias can be very common. So a lot of times people don't like to socialize for one reason or another. Sometimes there's certain fears or past traumas that can cause this, or PTSD. More recently, COVID. COVID can scare that geriatric population into not being as social as they were before. So a loss of independence is when an elderly person begins to have difficulty managing their day-to-day lives. It can be physical, emotional, or social in nature. Some examples can include difficulty walking, losing sight or hearing, a decrease in physical energy. These difficulties can lead to weight gain, increasing irritability, and moments of confusion. If you see this as a practitioner, you should be able to listen to their concerns and hopefully help them cope with some of the difficulties that are happening. Be honest with them and help them ask for help when it's needed. We should have appropriate communication with the geriatric population. We should be using their names when speaking to them instead of saying things like sweetie or hun. That can be seen as disrespectful, even if it is cultural in nature. We should also be careful and not assume that they are hard of hearing just because they are older. It's possible that they can hear just fine, or that they have a smaller hearing aid that you cannot see, or that might be quite hidden in there. Some of the larger hearing aids, you can actually see the outer part and then the inner part, and then they get smaller and smaller as technology advances, and also more comfortable to wear when they're smaller and more discreet. So if they tell you, I can't hear, I don't have my hearing aids in, then by all means, speak up in volume, but do not just assume. So assessing your geriatric patient, pharmacology, to touch on this briefly, if you've ever heard your patient say, I don't have high blood pressure, I take medication for that. There's quite a few people that believe that because their prescribed medications fix their medical conditions, or they're not having symptoms of it because their medication is working, they'll tell you that they don't have a medical condition. So when you ask for their medications or get a list or look at the bottles itself, go with the diagnosis for that blood pressure and maybe be more inquisitive to them for it. There's also another common occurrence of having multiple doctors that don't communicate with each other. There's going to be different treatment plans, different prescriptions that are prescribed. This causes overdosing and medication interactions that can be very harmful to these patients. Their kidneys aren't functioning properly. There's a psychological, possible altered mental status component to it. So if you start to see multiple drugs on top of each other that are taken by this patient at once, you might need to ask more about that, especially a sleep aid, an anxiety medication, and a pain medication all at once. Those together can cause for some problems. We also must ensure that we are gentle when we are assessing our patients. Different interventions like blood pressure cuffs can cause bruising on the arm very quickly. Skin tears are so common. So a minor bump can cause a big bleed for them, especially when they're on blood thinners. Blood thinners are a common thing for geriatric patients. There are common medical and trauma problems. There is altered mental status, and many issues can cause it. Sometimes it can be reversible. You'll need to do a very thorough assessment for these patients if it's not a clear reason why. Checking a blood sugar can also assist with determining if their altered mental status is stemming from that problem, which will lead you into your high and low blood sugar problems. It is very common due to the either renal failure or the diabetes that has occurred throughout their life. If a low blood sugar is mistaken for a stroke, it can be treated wrong. Also, using your blood sugar as a baseline vital sign will also help bring attention to this possible problem quicker. Respiratory emergencies. Respiratory and cardiac emergencies will need detailed assessments and immediate treatment. You will see oxygen delivery devices in the field, air compressors, and you'll need to understand how they use those equipment. If there's a portable oxygen tank, that they would probably need to bring it to the hospital with them. Coming discharge, they're going to need a way to get home if they require that oxygen. So more common medical and trauma problems. The older we get, the less we are able to regulate our temperatures. The environment can cause this to worsen. This particular population has a hard time. When a geriatric patient is placed on a backboard, they can become susceptible to secondary injuries like hypothermia and hypoglycemia. So if your transport times are long, sometimes you can see these secondary injuries begin before arrival at your destination facility. Sometimes it doesn't take very long. Most people tend to be older in nature as they get older. So you'll see heaters being on in the house in the middle of summer. They'll be covered with mini blankets, or they'll wear long sleeve shirts when it is hot out. So they're already not able to regulate their temperature. Falling with the geriatric population is so common. It accounts for 70% of accidental deaths. 90% of these falls, the patient will have a hip fracture that comes from this fall. In nursing homes, 60% of residents fall each year. What is really great is to see when a nursing home has a protocol that states you will call EMS if a patient falls. Due to the fact that there can be slow bleeding, there can be altered mental status that some people won't pick up on, but also if they get an immediate CT, it can also help get to the root of the problem quicker. Advanced directives and living wills are different documents. Your advanced directives are legal documents that spell out end-of-life care and what that patient wants very specifically. Definitely, it is best to follow your patient's wishes for that care. If you are presented with an advance directive, whether it be an in-hospital advance directive or their wishes presented, spelled out. And you can call your medical director for assistance if need be. These can qualify and help state your case. To not start compressions, most states utilize a do not resuscitate order, which is an out-of-hospital DNR also. For EMS, we look for that state official completely filled out with multiple signatures, like a witness signature and a physician signature, as well as the patient signature on it, filled out completely with diagnosis, and it is a legal binding document for these patients to not start compressions or heroic measures, including intubation, and sometimes it goes up to CPAP. So palliative care, it can be performed on these patients, and a lot of palliative care is pain management. Oxygen also qualifies as a palliative care measure. It is not a heroic measure to put a non-rebreather on. It depends on your medical director in the state, I believe, as far as your CPAP regulations. And also your advance directives, if you have access to them or if a family member knows or wishes, they can state yes or no, they want CPAP performed or not. So it is best to ask family members before transporting or when you arrive on scene if it is not available to you right away. Some people will put it on the refrigerator, their packet, or next to their medications for their DNRs and their any out-of-hospital paperwork that needs to go with them. This is a service that is designed for patients with terminal illnesses and injury. It not necessarily does that mean that they are going to die soon or fast. It does mean that they can, but these people can live with hospice for many years. Hospice is very goal-oriented in making the patient comfortable, giving them support, and also giving the family support. It's giving them a way to go through the terminal illness and deathing process in a very nurturing way. They will consist of nurses and assistants and stuff for them that will administer medications like morphine. We're all very used to the hospice nurse administering morphine in the field. It will take away their pain, and it is something that can also sometimes help with anxiety. They treat anxiety for hospice care also. That is also treatable in palliative care as well. Because the deathing process is a very scary process, especially towards the end for some patients. The anxiety aspect needs to get taken care of as well. So hospice can also have facilities set up where if it is known that that patient is leaving the hospital and is so terminal that they will die in the next few days, I believe 1 to 3 days, maybe up to a week, there are facilities that are set up in many areas that are homes, and they have a spa-like atmosphere. They have beds and a place for family to stay all together in a very large room. They provide all assistance and meals, and they help care for that patient in that process. Follow your local protocols. Most common protocols, if the family calls you out to a house and you are presented with their out-of-hospital DNR, their terminal illnesses, and their packet of information, and the family is scared because this patient is dying in the process of dying. The respirations are slowing, or pain management is not quite being taken care of. You can call their hospice nurse, ask for their information. Some of us are very used to talking to our small community hospice nurses that are available in the area, and you get on a name by name, first name basis with these nurses as well. So you may be called to hold their hand through some of this process because the family becomes nervous through it all too. So learning the words to say to help these family members walk through this with their loved one can be a very difficult process, but it is something that we can frequently encounter in the field. A topic that is not a fun one to talk about is elderly abuse. You are a mandatory reporter. It is vital that if you see something, you say something. So abuse can be neglect, it can be physical, sexual, psychological, emotional, financial abuse. It can be somebody seeing something commonly and still not being able to say anything to someone. It comes in many forms and fashion. If you pass off your patient to an emergency room and you give the report to the nurse about living conditions or family members not able, neglecting this patient, but agreeing to take care of them at the same time, living in the same house of filth or disease and problems, or it is obvious abuse to you or even suspected, do not rely on that nurse to call in your adult protective services call. You also need to report this as well. So if you take your patients out of a home that is covered in filth, they're septic, they finally agree to go with you to the hospital. They get better at the hospital. If you don't say something, even if it may not get fixed, but a report in a trend of reporting this house, this patient has to go back home. And that home, if it's not cleaned up, this problem's only going to occur probably again. So these people need to get taken care of or get the resources to get help. And if they may not say it themselves or reach out for help themselves, sometimes you might be that patient advocate. So you may be doing them a service if they are unable to or embarrassed to do it themselves. Abuse is defined as an intentional or negligent act by a caregiver or any other person that causes harm or serious risk of harm to vulnerable adults. Look for bruising in places that would not commonly have bruises that are of varying healing stages as well. Look for their housing environment and what they have access to. If they're bedridden, if it is unsafe, if no one is taking care of them, if they mention things to you as far as a caregiver possibly stealing from them, that is also considered abuse. And it may go deeper than that too, but that might be an open door for them to start to talk. All cases of possible abuse must be reported. So please don't hesitate. In conclusion, geriatric emergencies make up large amounts of our call volume. These same patients make up many ER visits every year. We must understand how the body works with the aging process to understand how to treat our geriatric patients. Be gentle, talk slow, and listen for their entire response. Remember to always be respectful when doing your assessments and with your communication as well. Better knowledge of body changes that happen when you age will provide better care for your patients. Our next topic is disaster management. We're going to discuss challenges presented by most natural and technical hazards. We'll describe the role of the responder during a catastrophic event. We'll also identify the roles and jurisdictions of federal agencies that would support medical operations following a disaster or a catastrophic event. Types of hazards. You can have a natural hazard, which is an event originating from the physical environment, radiation from the sun, gravity, flow from within the earth. You can have a technological hazard, which is a hazard agent related to industry, structure, computers, transportation systems. Civil conflict hazards are violent events that have a potential to produce mass casualties. Challenges for the incident commander. Large-scale evacuations could result in injury and exposure to dangerous conditions for both the responder and for the people that are being evacuated. Victim tracking is a challenge when patients are being moved from hot zones to warm zones to cold zones. There's also a possibility where they load themselves up and drive themselves to hospitals by themselves. Medical standby must be coordinated and provided for the responders on scene. These people are a dedicated response unit to only the first responders. And sometimes it is needed that there be multiple first responders for the responders. There are agencies and there are volunteer people who do medical standby or they do rehab for large-scale events that you can call. Communications can be limited. You can have down radio towers, phone towers, and communication will become an issue. So a challenge is going to be locating alternate modes of communication. Your pre-incident plan. It is a valuable tool when responding to a call. It assists most fire departments with FDC connections, with floors where your hazmat rooms are, where the kitchen is, where the daycare is located in a huge office building. There are plans that can be loaded into software. This software can also communicate with CAD systems. It also uses Google Earth. It can do a street view. It can take a picture of the building of all sides. You can mark and write and click notes as needed. So these pre-incident plans can also help EMS as well, especially when trying to locate victims, when trying to understand what is involved inside of that building and what is going on at that moment. These things can also be flagged as well, these buildings. So pre-incident plans can play a huge role. If it is done before an incident occurs, it can help with education, with training, with conversation. And it also gets you in front of the public so that the public isn't as nervous should a large-scale event happen, like a large flood. And now you know exactly where the local hazmat room is in the hardware store. There are parts of the National Incident Management System that utilize pre-incident plans. The form that is filled out is an ICS 206. Emergency management got started back in 1941 with the Office of Civil Defense. In 1974, we passed a Disaster Relief Act. The establishment of FEMA, which is your Federal Emergency Management Agency, began in 1979. Your Emergency Management Assistance Compact came in 1993. Your Homeland Security Act and your United States Department of Homeland Security were developed in 2002 after 9/11 terror attacks. There are 4 phases to emergency management. Your first one is going to be mitigation. This is an effort to reduce a loss of life and property by lessening the impact of a disaster. Your second one is preparedness. Your pre-incident plans, your training, your tabletop discussions, engaging in these activities before the event occurs to establish a state of readiness. You're obviously never going to be able to cover every topic or occurrence that could happen in an event, a disastrous event, or a large-scale catastrophic event that if multiple things are ready to deploy at the beginning of that event, it can lessen the impact in the aftermath of that event. Our third is going to be a response. It's activities that occur right in the aftermath of a disaster. Priorities at that moment are life, which is first. Then comes property, then the environment last. Your fourth phase is recovery. This is a more long-term look on emergency management. Is more effective if it is planned for before a disaster. Some of these things can be considered before. The psychological conditions of the people that were impacted by, there is Red Cross that can help. There are local grocery stores that can assist with providing food. There are local warming centers. There are local areas where people can be evacuated to. Churches will open their doors at times. Other communities will step in and help. Housing reconstruction, household recovery. This takes time because debris needs to get cleaned up. Your environmental structures need to have some recovery, and they need to get fixed before reconstruction of housing can be done in times. Your infrastructure management needs to get activated. Debris management, donation management as well. You don't want more of one thing and less of another. You need to be able to use things like social media, use the news outlets to request specific things. Watching a lot of hurricane evacuations and watching a lot of fire response, like in California, the huge wildland forest type fires, where they ask for specific things when households become harmed. They ask for donations of gift cards or cash specifically, or very specific toiletries. We only need shampoo and we only need soap. We don't need clothing anymore. Those kinds of things need to be handled. So there are many emergency stakeholders that an emergency manager must consider, and they're going to make decisions that will directly affect all these stakeholders. Your stakeholders are going to be broken down into categories of households, emergent groups, governments and non-governmental groups, businesses as well. So, incident command system structure. This structure will grow when it needs to grow. and will reduce in size when it's ready to reduce in size, when it's time to reduce. It can have many arms and branches. We try to use a unified, one common ground for command. We try to all be underneath the incident command system structure. So if we are going to assist in a different state, or if someone else comes to assist us in a disaster, we can all communicate very clearly and we understand the structure that we're going into. So greater efficiency, coordination, and communication for incidents. It's possible to have many different agencies responding to that event to go help. Freelancing is not acceptable. Things need to be guided. Under command, there's an operations side. There's also a logistics side. Underneath operations, you have a medical branch that is then divided into a medical supervisor. Then you can have a transportation supervisor. Sometimes we'll utilize slightly different titles, or we will stagger some of these titles to when we are delegating these responsibilities out. Triage is a normal thing that is initially occurs after an incident happens. When a large incident happens, there will always be a difficult time tracking your victims. So some go in their personal vehicles or their friends' vehicles to hospitals themselves. Some don't feel they're injured, or they don't feel their injury until a little bit later. And they decide to then go to the hospital system. It's possible that even though you might be using a pre-made triage tag, the coding system may not get utilized by that hospital. So tracking of that patient once they go through the hospital system is not done. We like to gather statistics on not only just our victims, but are we taking them to the most appropriate hospitals? Are we using a triage system that is appropriate for large-scale events? What do we need to tweak? How can we help the population or the responders? How can we make these things better? And a lot of that is done through victim tracking. There's a lot of confusion on large-scale events. There is chaos as well. Some famous incidents where victim tracking has been so difficult has been the Boston Marathon bombing and the Las Vegas shooting. There was multiple problems with staging and triage and victim tracking. It was efficient. However, after reading a lot of post-incident debriefings for these incidents, there's always something that you can see later that might work a little bit better. And victim tracking, I think, will always be a difficult challenge. So medical standby, triage, and transport. An initial goal for IC is to mobilize the appropriate number of medical units within the first few minutes. And utilizing your mutual aid, your air, and your fire response. There should be a medical unit available to care for the emergency responders, and this unit should not be involved with the transportation of victims. Responders should use the START method of triage or something very similar. The majority of US uses START triage, and when you are utilizing START triage, the colors that are given will signify who is transported first. Patients should be transported to the most appropriate facility and should be transported in the order of red tagged patients first, which are immediate. Next will be yellow. These patients can be delayed up to a few hours. And green. Green patients, when they are tagged, are also called walking wounded. When you are transporting to a hospital, or if you are in charge of finding hospitals that are capable, you need to ask what a surge capacity is for them. This is the ability of all the components of the healthcare system to manage an influx of patients. They need to have enough staff to care for all these patients. They need to have the stuff to care for them, the space available, and the system. There are some emergency rooms that are very qualified to take care of them. However, on a busy night, to intake 50 critical patients is not going to end with a good outcome. Patients need to get divided. Patients need to get divided amongst multiple hospitals in an area if possible. And also, these hospitals need to be notified ahead of time that there was an incident and you are looking to transport 6 to 10 patients to their emergency room. Would you be capable of handling them? The National Disaster Medical System. This is an asset sharing partnership. It's going to provide emergency medical assistance to states after a huge disastrous event or major emergency. This system cares for victims of any incident that exceeds the capabilities of the affected local state's resources. NDMS is now a partnership with Health and Human Services, the Department of Defense, Department of Veteran Affairs, Homeland Security, your states and local governments. The National Disaster Medical System has 3 major components. You will see direct medical care, patient evaluation, and then a non-federal hospital bed system being utilized. Broken down and elaborated a little bit more. Primary objectives: to provide health, medical, and related social services response to a disaster area in the form of medical response units or teams and medical supplies and equipment. And we will talk about DMAT and DMORT in another few slides. Some of us have been involved in strike teams as well, which have been deployed for major events that have happened. To evacuate patients who cannot be cared for in the affected area, and they need to be moved elsewhere in the nation to a place that is capable, but it is a designated location for them. They will provide hospitalization in federal hospitals and a voluntary network of non-federal hospitals that have agreed to accept these patients for them and to work with this system. The major components of the National Disaster Management System. You have a deployable medical response, which consists of DMAT and DMORT. Your DMAT is the Disaster Medical Assistance Team. Also your DMORT is Disaster Mortuary Operational Team. This is made up of medical personnel. You can have physicians, RN, paramedics, you can have LVNs. There's also room for first responders and first aid type response too. Patient evaluation is coordinated with Department of Defense in concert with Health and Human Services and FEMA. In the event a local area is so overwhelmed, they can request for federal medical evacuation assistance. Definitive medical care is done by Department of Defense, Department of Veteran Affairs, and coordinates it with non-federal hospitals as well. These buses on the bottom left of your screen can carry very many amounts of people to different locations. Come in evacuation, especially of injured people, these buses can be deployed from their regional assets, and they can be shared amongst regions. It might take some time to get them to the area, to drive them to the area, and to get the proper personnel that come with these, we call them ambuses. It can also take a little bit of time to get them to your area. However, there are many assets like that available when needed. Your state and public health agencies. States will have the ultimate responsibility for their state's public health programs, including public health laws. The local health departments oversee operations and implementation of routine disease surveillance and epidemiological investigations. They're going to oversee and track, keep statistics of patients like tuberculosis. When COVID came, they picked up the numbers on that, and they started tracking very closely where increases were, and what we started calling as hot zones for it. Communication between state and health departments and federal agencies has rapidly moved to the forefront through preparedness plans. In conclusion, emergency managers must consider all hazards, all phases, all stakeholders, and all decisions that are made, because it will impact those people. The healthcare system surge capacity and capabilities to respond are critical to planning how an event will unfold. Although disaster plans have been used by communities and hospitals for decades, the response to a mass casualty with a preparedness plan has greatly improved the outcome of a disaster. Our next topic is going to be managing stress for fire and EMS personnel. We will discuss the importance of stress prevention and management for fire and EMS, talk about signs and symptoms of stress. We will discuss common stress prevention and stress management, identify additional stress prevention and management resources that are available to all fire and EMS personnel. Epidemiology. Fire and EMS personnel are exposed to various types of incidents. You can have acts of violence, horrific injuries, emotional distress of your victim and yourself, death or dismemberment, severe injury or death of a fellow first responder. Averting physical health issues. The physical demand is not just physical, it's mental and emotional as well. All of those components can cause for reduced immune systems. They can cause for further pain. It can cause for further tension being held, muscle strain, injury on yourself when that happens. It can also trigger other problems to be worse. If it's not a PTSD trigger, it could be also a medical condition to be worse. You are exposed to multiple toxins, and it will place you at risk for cancer. Prostate, testicular cancer, multiple myeloma, and non-Hodgkin's lymphoma are going to be your common cancers that are found. Conditions such as psoriasis, asthma, diabetes, high blood pressure can greatly be increased due to stress. We're already not sleeping well. We're already not eating well. We're up all night. We don't have a circadian rhythm, right? You can cause yourself to spiral into long-term medical conditions. Avoiding burnout. Some of us know of a partner that we have said they're just burnt out. You don't want to work with them anymore. They're miserable. They're unhappy, or they're making mistakes that are not normal for them to make. They're irritable, they're grumpy with you. It's not going to be a fun shift sometimes when these particular people are burnt out and they're still working with you. We also need to pay attention and watch for these symptoms of burnout in ourselves. We need to be able to learn how to cope with some of these, how to make these better, fix, correct these issues, possibly, before they can get out of control. So due to the demands of our job, we can have compassion fatigue. Just get cold to it all. You can become a robot. The feelings of being overwhelmed, you're indifferent, emotionally, physically drained, you're exhausted. You've had no time to recover, and you're back again for another busy 24. It can be preventable. So stress prevention activities can reduce the development of these burnout symptoms. Mental health and stress. Fire and EMS personnel are at high risk of developing PTSD, depression, anxiety, panic disorders, and increased use of substances. That includes alcohol and drugs. Stress management and prevention decreases the susceptibility to developing mental health or worsening pre-existing issues. Here's another incident when if you see something, you should say something. Suicide is a big problem. Due to the nature of our profession, first responders are at increased risk of having suicidal thoughts and ideations, their behaviors. A lot will die by suicide. In the year 2015, according to Firefighter Behavioral Health Alliance, it reported that 131 firefighters and EMS suicides happened that year. Although that number is thought to be much higher. Providing stress management techniques and knowing how to detect the dangerous signs and symptoms of extreme stress allow for the possibility to prevent suicide. If you have a partner or a best friend who you start to see signs, physical, emotional, mental, behavioral health signs, you might feel the need to ask, are you okay? I am here for you to talk with if you need somebody to talk to. I can listen. Things like that might open the door, even if they don't want to right away. Possibly engaging in fun activities that that are healthy activities. Starting a daily walk program can also help move some of the stress of the job around. Something very simple. And it can also open up communication lines. So our physical signs. Due to the body's normal fight or flight mechanism, the body can be under lots of strain. Your fight or flight comes from your sympathetic system. And if you go back to that, your parasympathetic system we call feed or breed or rest and digest, right? Slower. It's the one that's just going to kind of maintain your body. Your stomach, your digestive fluids are going, your veins are flowing just fine, your heart rate is going normal. We're not fighting. We don't need to run from anything. We're not scared. We don't need to fight. When we're stressed, this sympathetic system response begins to kick in. Your sympathetic response system is going to be increased heart rate. You will start to constrict and move your blood volume to your core so that your brain and your heart and your core starts to utilize that energy that is needed, the oxygen that is needed. It will also improve a blood pressure as well. And so you start, your eyes dilate so you can see further. However, the hormonal response to a long-term fight or flight can be very detrimental. If you've been holding your muscles under tension for so long, you can begin to have pain. And now you can begin to compensate for it. You can injure yourself by doing something as simple as bending over and picking up an object that is 5 pounds. You can tweak things or sleep just wrong. You start to clench your jaw and grind your teeth. You get headaches. You can begin to really start to hurt yourself this way. So we need to find things that are going to slow this response down too. Breathing techniques can work wonders. I know it sounds funny. Yoga is another thing also to keep your body in a slower state. You can also engage in fun things like hobbies, music, exercise. Exercise will also release a dopamine, which is a fun feeling, the good feeling drug in your system, right? Your emotional signs, stress plays a vital role in your emotional health. If you go home and you're snappy, you're irritable, no one wants to be around you at home because they're walking around on eggshells and they're not quite sure how you're going to react because you are under tremendous amounts of stress at work, it can be a sign that you need some help. Other signs include dramatic mood swings, difficulty concentrating, isolating yourself, especially when you're not known to isolate yourself. Our mental and behavioral health signs. The most common type of anxiety for first responders is going to be a general anxiety disorder. Parts of the examination for anxiety disorders have included 3 of the 6 following symptoms: restless and on edge, fatigue, difficulty concentrating, easily irritated, experiencing muscle tension, having sleep issues. Sometimes your sleep is not enough or you're sleeping too much. I think a lot of us go to the not enough, go the insomnia route because we're overthinking a lot. So PTSD in the first responder, it's now being recognized. Thank goodness that firefighters and EMS are very susceptible to developing PTSD. There are 5 categories that are associated with a PTSD diagnosis. The presence of 9 or more can lead to a diagnosis. These categories include intrusion symptoms, avoidance, negative thinking or a negative mood, dissociative symptoms, and arousal symptoms. Addiction. A lot of us in this field joke that we're self-medicating or we're going to go have a 7 a.m. beer at the bar when we get off duty because we had a long shift. Alcohol is fine in moderation. When abuse begins to happen with alcohol or drugs or anything for that matter, it becomes more of a dependence, and it will start to affect work. It will start to affect everyday life activities for that person. Here's another instance where you might want to say something. If we've seen a friend that Started with a few beers a week, moved into a few beers a night, moved into a couple of cases a night, or start drinking to the extremes of blackout all the time. We might need to say something to see if maybe we could help get them to treatment. If there is a partner or someone at work that you're kind of suspicious of, maybe ask them, are you okay? Is there, I've been noticing that, I just want to make sure you're feeling all right. Those kinds of things. We want to help people not be dependent on a substance. So addiction can present in many forms. Obviously, we have alcohol and prescription drugs, and illegal drugs. There is also gambling, smoking, caffeine, which please don't take our caffeine away, sex, shopping, internet, video games, food, working. And that's pretty hard to tell us, right? We are caffeinated and we are workaholics, but when it's taken to an extreme, when you've got that person that works 5 different jobs in the same community and they just rotate all the time and they never have downtime, it might need to get recognized as well. Stress prevention and stress management. Ultimately, identifying the triggers is going to help the next steps. If you don't know what is causing your stress or your PTSD triggers, you might need to try to slow down and think about things that could cause it. So if you start to encounter them in the field, maybe you can utilize a breathing technique or a coping skill that you have learned or read about to help assist you in this. You can also use medications, alternative medications. So your trigger is going to be something you see, hear, touch, taste, smell. It's a sense. It's going to bring it all back. It's going to bring back that negative feeling. It's going to activate that sympathetic response. You could be sitting at dinner with your family, have a flashbang, and immediately go into a sympathetic response. Your heart rate's going to increase. You get sweaty. You get short of breath. And you have no idea why you thought that. Why? Why would that cross my mind? Those are things that can happen to you. So triggers, maybe you smelled something that triggered you. Maybe you heard something that triggered you. Very possible. Triggers can also be places. They can be people and certain items too. It is different for everybody. Recognizing these triggers can be very important. If you find yourself overreacting to something or a past event, maybe try to slow down and look at what a possible trigger could have been for it. Coping skills and self-care. However you find self-care, you need to make sure you set time aside for yourself to do those items and those things. If it's a pedicure, go get a pedicure. If it is yoga and stretching, if it is sitting in a quiet room for 5 minutes every morning, those things matter every day. If those are your coping skills and what works for you. Once you have found your trigger, you need to look up your resources, ask for help, try to find what could help in a healthy fashion. Stretching reduces stress, yoga and stretching. That includes your breathing and meditation also with yoga. Team sports are fabulous. Exercising already puts that endorphin, that rush, your dopamine increase. Also, socialization aspect of team sports and utilizing a gym or going with a group on a hike. It can have connections, cause connections that can keep you from isolating yourself. Relaxation techniques. We've already talked about breathing a lot, right? Writing in a journal, getting the words out on paper sometimes can help you too. Those are some of the techniques that are available to you. Anger management techniques, knowing when to walk away from a situation helps decrease stress. It is okay to say no, thank you, not right now. I'll visit with you in 5 minutes. Just give me a minute, right? That's okay. It's okay to gather yourself as long as you need. Those things are fine to do. Spirituality, going to church, praying, finding your meditation spot. Those things, members can give you interaction with people. It can give you hope. It can give you support to have that belief system. It's helped many people through personal crisis. And good sleeping habits. Very, very hard to get good sleep. Very hard. Here are some ways. You can limit your caffeine and alcohol consumption before bed. Yes, alcohol consumption. Yes, it's going to make you sleepy. However, your kidneys are going to be pumping. You're going to be trying to detoxify while you sleep. If you get up 3 times to pee during the night, you're not sleeping really good. So maybe saying, I'll stop all caffeine at noon or 2 o'clock. Limit yourself to, I'll have 2 cups of coffee today. That can also help. Avoid taking naps sometimes. Sometimes. When you're on duty, it's hard because are you going to get sleep at night or not? So sometimes we do like to nap while we're on duty. But if you push yourself and give an early bedtime, if you do wake up early, it's fine, but you might start to get your circadian rhythm on board. Eliminate noise and light. Your pineal gland, which is located in the back of your head, secretes the hormone melatonin. Melatonin is secreted in the dark. Your rods and cones in your eyes start that process for the light and the dark, and that will trigger your melatonin to start being secreted from your pineal gland. It's a hormone. It's a natural hormone. So reducing the noise, which will stimulate your brain, reducing your light, which will increase your melatonin, and working on a meditation can assist you in falling asleep very quickly. There are sleep hypnotherapists out there that can assist in sleep therapy for you as well. They are available. They do work. They do. If you're open to it, it does work. You can create an environment where you want to go to bed, where it's comfortable. My oasis, and I am ready to sleep. You can avoid looking at TV screens, phones, laptops, tablets. Don't doom scroll till you get sleepy. A lot of that will trigger a response in your brain that will keep you awake. A lot of times they say eliminate it about 20 minutes before you want to try to get to sleep. And it will drastically help getting to sleep. Some people can't sleep unless there is a TV on. So by all means, turn on your TV. But utilizing relaxation techniques and getting vitamin D during the day. Go get some sun. There is a peak time and a time limit to getting some sun, but taking a 30-minute walk outside in the fresh air, getting that natural vitamin D, which is very different than a supplemental vitamin D. It responds in a very similar way in your body. However, vitamin D is needed for a lot of electrolyte balance in your body. It helps with calcium, helps with bone growth. It helps with hormones. It helps with magnesium. And magnesium helps with your vitamin D intake as well, your absorption of it all. So we can utilize many techniques just to try to sleep better at night. Additional resources, we can include our department chaplain. Most departments have a chaplain that will aid in comfort. They can talk with a person if you become overwhelmed, and there are many more avenues after that. They can assist, a lot of them can assist with therapy, being somebody to continually meet with and to listen to you, and to also assist with your coping. According to NFPA, both paid and volunteer fire departments must provide access to behavioral health programs. If you feel you are in need, you need to ask. If you're ready for help in some way, you need to ask. It may be completely free. There are grants that are available for mental health, and there are programs that are available free of cost for first responders to utilize. And they are very much underutilized in this service. We need to get rid of the stigma that comes along with asking for help. There is nothing wrong with saying, I cannot get this thought out of my mind, and I need some help doing it. Okay, I need to get some help because I don't want to feel like this anymore. Great. The words in Al-Anon a lot are, I'm sick and tired of being sick and tired. And normally when that happens is when a lot of people start to speak up. Psychotherapy. EMS workers often do not seek mental health treatment due to this stigma. Doesn't mean that you are incapable of doing your job at all. And therapy is a good way to help cope with stress. In conclusion, although this job is very rewarding, first responding can be stressful. Repeated exposure to traumatic events, harmful exposure, our emotional capacity is at limit, at its upper limits. We also need to understand the symptoms of potential mental health and addictions. You can see it in yourself, possibly. You can see it in a coworker. Utilizing various coping methods will help to decrease the stress involved with the job. Changing the stigma of EMS and fire personnel looking for mental health must be a priority for all. And I can say it can start from you and within. You can always be that voice of positivity for this to change this in your job if it is not being done already. Here are some additional resources if you do need help. The Code Green campaign is a large campaign that helps with mental health for first responders. Very specifically, they are amazing. They offer free assistance a lot of the times, and they will get you where you need to go if they can't do it themselves. 911wellness.com. We also have Share the Load support programs. Suicide prevention lifelines are available. The suicide hotlines, suicide.org. Also, International Critical Incident Stress Foundation. Thank you for joining us, and we will see you later.